Lung cancer is often in a person's life the first really life-threatening thing that hits people, especially when you're otherwise healthy 40-whatever-year-old person.
Well, usually we talk about the actual diagnosis and what does that mean, and talk about how important different subtypes of non-small cell lung cancer are compared to small cell lung cancer as well, and then what the subtypes or the histology actually determines for that patient. And then talk about staging as well. You know, what are we trying to cure the cancer, or can we only try to control the cancer? And so patients with metastatic disease or disease outside of the chest, technically we say that we can't cure that patient, but we certainly can try to control and improve quality of life and prolong someone's life as long as we can.
So most commonly patients will get a CAT scan, at least of the chest, if not also a chest, abdomen, and pelvis CAT scan. A CAT scan stands for computed tomography scan. Basically, you can think of that as a very high-level fancy X-ray, but doing multiple what we call slices of your body. And so with that, we can look very closely at what's going on in different parts of your body. We also will order what's called a PET scan. That stands for positron emission tomography scan. And that works differently in that what you're given is a radioactive, basically a sugar molecule. And the thought is that the sugar molecule will go to areas of rapidly dividing cells. And most often, the cancer cells are rapidly dividing. So what that test will show is if the cancer really has spread to any other place, like the bone or the liver, for example. The other test that we get is an MRI of the brain. And the reason we do that is, unfortunately, lung cancer likes to go to the brain sometimes. And so the MRI would tell us if there was cancer there or not. And often, if there is cancer there, then we need to do something about the brain lesions first before we can treat the rest of the cancer in the body.
Right now, one of the hot things or newest things is lung cancer, is that CT screening looks like it probably will have a big role in diagnosing lung cancers earlier. But the reality is that CT scans have lots of little nodules. We all have little things in our chest, especially if you're in an area with certain kinds of funguses and bacteria. And being able to tell a good nodule from a bad nodule, or one you can watch from one that needs to come out, is still really hard.
Whatever therapy we pick, we try to personalize that somehow, including trying to avoid certain toxicities that are important for them to avoid, as well as trying to make sure that the therapy works the best that it can.
In the past, we had a lot of clinical trials where patients with advanced stage non-small cell lung cancer were given chemotherapy to help them live longer and control the symptoms related to the cancer itself. And in those studies that looked at combinations of usually 2 different chemotherapy drugs, none of those combinations looked any better than any of the other combinations. So we knew that they all could help people live longer and on average help people live better by controlling the symptoms of the cancer.
What matters is what's deranged in your cancer that makes your cancer different from your normal cells. And the differences in response and benefit of particular drugs is tightly linked to that knowledge. I think it's important for patients to realize that they do have a variety of options that depend upon this kind of genetic analysis of their tumor, and make sure that their oncologist is aware of this and that the samples, their tumor, is appropriately analyzed.